Welcome to this episode of OncLive Breast Cancer Talk, where we'll be discussing new updates on systemic therapies in both early stage and advanced breast cancer. I'm your host, Dr. Sarah Sammons from Duke University in sunny Durham, North Carolina. Here with me, I have today are all rising stars and experts in the field of breast oncology. We have Dr. Julie Collins from MedStar Georgetown Hospital in Washington, D.C. We have Dr. Kelly McCann from Ronald Reagan UCLA Medical Center in Santa Monica, California. And we have Dr. Laura Spring from Massachusetts General Hospital in Boston, Massachusetts. Today, we hope to provide you a unique and fresh perspective on clinical decision-making and treatment selection from an early career breast oncologist perspective, based on key data sets presented at this year's all virtual meetings, including ASCO 2020 and ESMO Breast 2020. Now let's get started on our first topic, which we're going to discuss hormone receptor positive, HER2 negative advanced breast cancer, and one of the most exciting studies to come out of ASCO this year, which is the PARSIFAL study. And when we get into before we get into PARSIFAL, I want to talk about what's really the standard first-line treatment for metastatic hormone receptor positive, HER2 negative breast cancer that is endocrine sensitive or endocrine therapy naive. So when we talk about endocrine sensitive, we mean that they have either relapsed greater than 12 months after their adjuvant endocrine therapy, or they're endocrine therapy naive. And based on the phase 3 clinical trials, Paloma 2, Monarch 3, and Mona Lisa 7, most of us would give these patients in the first line setting a CDK4/6 inhibitor with an aromatase inhibitor. The question of the PARSIFAL study was really whether or not fulvestrant with a CDK4/6 inhibitor would be superior to an aromatase inhibitor with a CDK4/6 inhibitor in an endocrine sensitive or endocrine naive population. And the reason that they asked that question was based on a previous study called the Falcon study that was published years ago that looked at endocrine naive patients in the first line setting of hormone receptor positive advanced disease, and they randomized them to first line fulvestrant or first line arimidex. And that study actually showed that fulvestrant was superior to an aromatase inhibitor in the first line setting, which led to this question of PARSIFAL. So PARSIFAL was a very large randomized phase 2 study. It was a total of 486 patients with advanced hormone receptor positive HER2 negative breast cancer. They had to have no prior therapy in the first line setting. They could either be endocrine therapy naive, or they could have relapsed after endocrine therapy after greater than 12 months after ending their adjuvant therapy. And they were randomized 1-to-1 to receive palbociclib with fulvestrant or palbociclib with letrozole. The primary endpoint was investigator-assessed progression-free survival, and patients were stratified by visceral involvement or whether or not they had de novo or recurrent disease. The results were presented at ASCO 2020, and they were actually quite surprising. The median progression-free survival in the palbociclib fulvestrant arm was 28 months, and the median progression-free survival with the palbociclib letrozole arm was 32.8 months. So fulvestrant with palbo was not superior to letrozole with palbo. I think this was a surprise to the investigators of the study, and what it really showed with a hazard ratio of 1.1 is that there was no difference between the endocrine backbone. They did look at different subsets of patients. They looked at subsets of patients with visceral disease or no visceral disease. They looked at subsets of de novo versus recurrent, and there was no difference between either of the endocrine therapy arms. So I think this is a really important trial. We certainly want to be giving our patients the best endocrine therapy backbone in the first line. And what this trial showed for me was that I think in an endocrine either naive or an endocrine sensitive population, that an aromatase inhibitor with a CDK4/6 inhibitor is probably what we should be using. Any other thoughts on this trial? How has it shaped your practice or your thoughts?
I think it will be very interesting when we have an oral SERD, because most women are not going to want to have a shot for 28 months.
Yeah, I agree. I think I was happy to see these results because it would, it's much easier to start with an oral agent over an injectable. So I think this was reassuring, but as you said, a bit surprising based on the Falcon data, although hopefully it really shows that it's the CDK4/6 inhibitor that's really, making the difference here. And of course, these populations being either endocrine sensitive or endocrine naive, we wouldn't expect a very high rate of ESR1 mutations.
Right. I was going to ask if there is an endocrine sensitive or endocrine naive population that at this point, based on this trial, that you would consider giving fulvestrant with a CDK4/6 background in the first line, which is good news for our patients because those 2 injections in the bottom are not fun. So I think we can, this population, it's very reasonable to start them on an aromatase inhibitor with a CDK4/6 inhibitor. I agree with, fulvestrant does not have great oral bioavailability, so it'll be really exciting to see what those oral certs show coming down the line. But for now in this population, I think AI with the CDK is the way to go. So next, we're going to talk about a particular subset of patients with hormone receptor positive, HER2 negative breast cancer. And those would be the patients that have activating mutations in the PIK3CA pathway. Julie, can you tell us about the BYLieve study that was presented this year?
Sure. So I think the BYLieve study built on what we know already about alpelisib and fulvestrant, which were approved in 2019 for PIK3CA mutated metastatic hormone receptor positive breast cancer patients based on that phase 3 SOLAR-1 trial where we saw an improvement in PFS to about 11 months versus around 6 months with fulvestrant alone. So this BYLieve trial is interesting because this is the first time that we see alpelisib and fulvestrant used in the post-AI and CDK4/6 inhibitor setting. This trial was a phase 2. It enrolled 121 patients and was presented at ASCO this year, focusing on those patients who had received prior AI and CDK4/6 inhibitor and then received fulvestrant with alpelisib on this BYLieve trial. Median follow-up was about 12 months, and the primary endpoint was met. So they were looking at disease-free survival at 6 months, and greater than 50% of the patients on this study in this particular subgroup had not progressed at 6 months. That being said, I think as we've seen in clinic, alpelisib is not always the easiest drug to give. Half of patients on this study did have diarrhea or hyperglycemia, each of those in more than 50% of patients. And there's greater 3 or 4 hyperglycemia in 28% of patients. So more than a quarter of patients had to be treated with insulin therapy. But that being said, it was interesting, the incidence of discontinuation was quite low, really just a handful of patients that discontinued due to adverse events. So alpelisib can be a tough drug to manage for both the patient and then also for the provider, in that we're managing these hyperglycemia meds. But the BYLieve trial provides further support of the benefit of alpelisib plus fulvestrant now in the post-AI and CDK4/6 inhibitor setting, which is important because I think first line now, in the majority of our patients, we're often treating them with AI and CDK4/6. So to have this data is very helpful for us.
Absolutely.
Has anyone had the opportunity to use this in a post-CDK4/6 setting?
I have, and I'm really excited about this data because, of course, the criticism of SOLAR-1 was that, this population hadn't had prior CDK4/6, and would that population perform as well? And I think this provides us some data that patients, if we can get them through this combination, it does have efficacy, which is great. I have been using it in the clinic. The toxicity is a bit of a challenge. I think we're all getting a little more used to using it. Is there anything that you all have been doing in terms of helping patients in terms of managing rash or the inevitable diabetes that happens? Is there anything that you've adopted into your practice?
I would start with doing an antihistamine a week before, and just to prevent the rash. And then almost everybody needs metformin. I'm not very comfortable doing my insulin, but I'll give them metformin.
Yeah.
And a referral to endocrine.
So actually at my institution, every 1 week before we start everybody on alpelisib, we're giving them all, it's Zyrtec, right? Yeah,
Exactly.
we're giving them all Zyrtec, and we're actually starting them all on metformin 500 BID a week before we start. We have a pretty hardy Southern population, so that has served us well so far, and we're hoping to publish that data soon. But managing the, as oncologists, we don't like new toxicities. This is certainly a new toxicity challenge in hyperglycemia for us.
Yeah.
The next thing I wanted to talk about in terms of this data, just quickly, is when are you all genomically sequencing your patients? Now that we have this approval, it's essential that we, check for PI3 kinase mutations. So are you doing that in the first line setting before you start therapy? Are you waiting until progression on a CDK4/6? How are you all doing that?
I'm waiting for progression after CDK4/6 because then I'm also looking for activating mutations in HER2, activating mutations in the estrogen pathway, and PI3 kinase. So that will help guide me toward the next therapy.
We've routinely been doing it up front. In part, we've had an internal panel available to us for several years, so it's just been very easy, even without insurance approval, to get that accomplished. So I think we just all got in the habit of that. We have also been using more of the cell-free DNA testing as well. I do find it somewhat helpful to know early on about a PI3 kinase mutation. Hopefully these are patients who are on first-line therapy for quite some time, but even knowing in advance, you can check your A1C, and if there is an issue, start to work on that. So I have found it helpful, to kind of help guide me for that next step.
And it seems like PI3 kinase mutations are early events. I only, because of insurance purposes, I think most of us are trying to genomically sequence once, so I want to get the most bang for my buck, which will usually be for me after CDK4/6 in case they've acquired a mutation. The other interesting thing that I think is clinically relevant is in SOLAR-1, 50% of the patients that did not have PI3 kinase detected in the circulating tumor DNA, I think did have it detected in the tumor. So if we can detect it, if we can get genomic sequencing on the tumor, that's always our preference, though it's not always feasible.